Hello everyone. So greetings of the day and welcome to Learnings on 24 into 7. Myself Deepa Maria Raju. I am a clinical nurse educator. So the purpose of introducing myself and my channel to you all is because nowadays it is very important that we all need to get updated with our profession. At the same time, we all are undergoing in-service nursing education. I'm sure all of you are attending. It is by extending your working hours. So please join me in this platform so that you can learn at any time, anywhere, according to your convenience. So that's about learnings on 24 into 7 as a short. And now, in this session, I'm going to discuss you about medication management and usage. So, in this platform, throughout the videos, you will be watching different videos which are very particular for us as a nursing professional, and it is very much pertaining to the IPSGs. I am sure that you all are aware and much more aware about IPSGs. So, it will be putting more light into your professional life and career so that you can build up your career and you can up to date with the current nursing practices very clearly and thoroughly without spending much of your time. So this is medication management and usage for this session. So medication, yes, we all are very familiar with this procedure, and in our day-to-day life, maximum time or most of the time or in almost all the shift, we are doing this procedure without any problem. So whenever you are hearing or listening about medication management and usage, you are thinking like that, yeah, it's a common thing. It's we all know. Yeah, I am also sure that you all know this, but still there are certain things which we need to notice much more, so that see, even if we are doing it in a daily basis or at most priority, still we are landing up in medication errors. Not all of us or all the institutions, but yes, of course there are different countries are reporting around 50% or 42% of medication errors, starting from the prescription till documentation or monitoring. So yes, still it is a major issue, and the medication management we need to discuss, and it is our core job. As an nurse, it is our core job. If the patient is able to have their medication by themselves at home, none of the patient will turn up to the hospital. So that shows the importance of medication management and how we need to get updated with the practices, or how we need to renew our policies or stick on our policies. So shall we go? So medications, we all are aware about different forms of medications, no? There are so many forms of medications that are available. And what is this medication different forms? Yes, I'm coming to that. These are the chemical substances, whatever is the form, whether it is a tablet, whether it is a capsule, whether it is an injection, all these are the certain chemical substances which is made into different concentration to treat, cure, or prevent, or even diagnose the diseases. Now, medications are in different forms already. I told you these all are the different forms. You can seen in the screen. I'm sorry. That is tablets or capsules in the form. Injections, there are different types of injections: intradermal, subcutaneous, intramuscular, intravenous, intraosseous. There are so many type. And inhalations, which we are taking like nebulizations or uh, even in the puff. Inhalations, transdermal patches, NDG patches, and sometimes morphine patches. These patches are available, and the suppositories, which we are inserting into the different body cavities. So, when we are talking about the medication management process, it is starts with the prescription, and without a prescription, none of us are allowed to move further in the medication management process. So prescription is not our job. Prescription is up means done by should done by a practitioner, licensed practitioner. None all the practitioners are not even allowed to prescribe all the type of medication. So we should know who is having the authority to prescribe particular medications. So nowadays it is also available in each hospital, like who all are having which all are privileges. And once the prescriber prescribed the medication, now we are into action. Now, in certain hospital transcription automatically done. If they are doing a computerized prescription, automatically the prescription will go to the pharmacy and pharmacy will process it. But when we are considering our system or our restrictions, most of the time we are supposed to do the transcription. Transcription means once we are writing from one place to another, we are just transcribing it. That means our indenting. We are indenting our medications. Most of the hospitals are doing it through the HIS, that is Hospital Information System only. So once we are typing these medications in the system will pick it up and we are putting the right dose and how much amount we need, we will put it into the pharmacy. Automatically the request, this transcribed thing or the intent will go to the pharmacy. Okay, then the pharmacy is doing the dispensing process. Dispensing means they are dispatching or they are packing, segregating all these medications and they are sending it to the departments. That is the process of dispensing. So there also we have a vital role. Just imagine, instead of Metrogyl, they are dispensing mannitol and we are not identifying it and we are administering it to the patient. We are landing it in a dispensing as well as administration error. So dispensation also is an important thing, and once we are receiving the dispensed medication, we need to be keen and we need to check what we intended and what they dispensed. Now, next is our core job, that is the administration. Administration means we are giving this medication to a patient, to a right patient. That is the process of administration, and which is followed by the monitoring as well as the documentation. We are supposed to monitor the patient after each administration, you know, and after that we need to proceed to the documentation also. So now into the detail about the prescription. The prescriber need to, already we discussed, the prescriber need to write the drugs in the drug chart or medication chart. We cannot follow now, as per the current guidelines and the policy, we are not supposed to follow the prescriptions the prescriber write anywhere else other than the medication chart. So we need to make sure that there should be a written order. Verbal order policies are not existing anywhere right now. So we need to make sure that the prescriber prescribed it in the medication chart with the name of the prescriber, with the date as well as the signature. So that is about the prescription in the medication chart. They should mention the right dose, right route, and the right frequency at the time of their prescription. Now, prescription should be in block letters. It is not compulsory for all the hospital. It will be based on the internal hospital policy. Most of the hospital is following this, because different people are having different type of handwriting and it is not possible to read or understand by everybody. So most of the hospitals are following the capital letter policy while prescribing, but as a general, it should be legible. Legible in the sense, if one of the nurse can read it, it doesn't mean that it is legible. Everybody who is having the access or who need to get an access to this medication chart should be able to read this prescription. That's all about this second point. That is, prescription should be legible, readable. Now, only standard abbreviations. Abbreviations are also, every hospital is having their policy, abbreviation policy. So whenever somebody is using these abbreviations, it should be standardized and it should be there in the hospital policy. We cannot write like TID, QID, or TDS, whatever it is, based on the abbreviation of the hospital. If it is TDS, they need to write TDS, not TID. So that is the another major important point with regard to the prescription. Now we need to write the medication if any dosage changes, rewrite. So if most of the time the prescribers, what they are doing, if one thing is of 1000 mg, that is 1 milligram, they want to reduce it or taper it to 500 mg. What they are doing, they'll cut that 1000 mg and they'll overwrite or overlap, and in the top they'll write that 500 mg, which is not acceptable. They need to rewrite the order. They need to cut the entire order and they need to rewrite the order. Okay, that is this particular medicine 500 mg. Again, they need to rewrite or re-prescribe. Now, discontinued medicine need to be highlighted. Yeah, that is a trend that we are not aware that discontinued medicine, maybe in a column somewhere they are writing D bar C discontinued. So most of the nurses or most of the person, they are having lot of other works also. So in a hurry, they are going and they are administering even the discontinued medications or even the withheld medication. So that's what this point is valid. Discontinued medicines need to be highlighted. So with the highlighter or something, we need to highlight it and we need to write there as discontinued. So highlighted things, obviously, the person who is accessing or who is accessing the chart or who is proceeding with the chart, they will be more conscious. So it should be highlighted. Orders should be legible and clear, which already we discussed. Now, another thing is decimals need to write clearly. Like, see, if somebody is prescribing 0.5 mg digoxin or something. So, most of the time they're writing 0.5. So, 0.5 can misread as 5 mg or something else. So, whenever there is a decimal, it should be written as 0 point. So that is another important thing regarding prescription. Now, when we are talking about the transcription or indenting, computerized indenting system is more accessible because acceptable because once their doctor is prescribing in the system, automatically it will. So this transcription errors, there will be no errors as somebody is rewriting it. So that is the acceptable thing. So when the RN is indenting the medicine, that is we are indenting the medicine, it is mandatory to use the drug chart. Most of the time, if I am sitting in front of the computer and somebody else in the patient side or somebody need a medication, they will just tell me, excuse me ma'am, please order this medication, please indent this medication. So I am just indenting it without seeing the patient's drug chart or without seeing anything. I'm just indenting it. So it can land up in error. I can indent a wrong dose or a wrong form of medicine. So that's another thing because while we are writing or typing in the computer is just picking up. If I'm, for example, if I'm typing Diator 10 mg, when I'm typing DYT, Diator is coming. So many Diator concentration is coming. So I can just click any of this. By mistake, I can click 100 mg also. So that can end up in a error if the nurse is not more checking it or means doing it in a proper way, it can also end up in an error. So whenever you are indenting, please make sure that you are sitting with a medication chart and you are doing a spell check and you are checking each and everything. Again, I'm remembering it's our core job. So checking each and everything, you need to indent so that indenting error will not be happening. Indenting error is a major thing. Yeah, most of the time we are not much bothered or looking into that, but indenting error is so many rather than any other error. Like for a particular department, every month, once in a day minimum, it is happening. So indenting also is a major thing, where we need to be much more alert. Then at the time of indenting also, we need to identify the patient correctly with the two identifiers. I hope you all are aware about the two identifiers about an IP patient, which is full name and the UHID, which is the hospital unique number. Do not indent for so many days. Yeah, that is another thing. Usually, most of the time, a common antibiotic or a common drug, we are just expecting that the patient will have this till the time of discharge. So usually we all are intending like that. And some hospital also allowing that. But most of the hospital is restricted the intending as for a day. It is very, very mandatory. Why? Because when you are intending for a so long period and in between the medicine is withheld or something by mistake, that medicine is continuing with the patient's medication cupboard, the assigners can give or administer the drug by mistake. So hospital should have a policy. So follow the policy. I don't know particular hospitals what are the policy, but most of the hospital is restricted is as a day, for a day, for a daytime, for a day period, they can intend. So restrict it according to your hospital policy. Now coming about dispensing. Dispensing means the pharmacy is distributing or giving the medications against their intent. So substitute to be used as per the hospital policy. You all know substitute. For example, if I'm asking for a Dolo, I'm intending Dolo. Dolo is not available. The pharmacy is replacing usually it with a Crocin. Most of the time they are doing like that, but there should be a substitute policy. I hope all of you are having your hospital policy about the substitutes. Like we cannot use each and every substitute. If they are using, there should be, maybe they need to call the nurse and they need to ask the permission, and if the nurse cannot give the take the authority, they need to consider further and get back to the pharmacy. So substitute policy need to be followed. Now, opened medicines or medicines without chemical name should not be received. All the medication, we all are aware, like if you are taking a strip, there is a brand name and the chemical name. So chemical name is not visible. How can we make sure that because brand names are different and different things, so make sure that it is belongs to the particular chemical name or particular thing. And open medications, please don't receive it. So when you are receiving the dispensed item, you need to be checking all these kind of things. Now receive the medicine and check against the order, like name of the drug, strength which we ordered, and the number count. Will it be sufficient for the for a day, or is it matching against your intent? So you need to check this kind of things. Now, after receival, medicine should kept in patient's bedside locker. So usually most of the hospitals are following this policy. We cannot keep the medications commonly in the nurse station because medicine can be get exchanged. Okay, that can also land up in medication or some other serious issue. Another thing is, after receival, we are just keeping it in the patient side, not in a locker or anything. Patient can consume it by themselves. So whenever you are just receiving the medication, make sure that you kept it at the bedside and you locked it, if it is possible. Or as per the policy, you have to store it safely. Now, temperature. Temperature is another major issue. Yeah, we all know there are medications which most of the medications are need to be kept less than 25 degrees Celsius, and fridge medications which is 2 to 8 degrees Celsius, we need to keep in the fridge. So these kind of things we need to take in into consideration. And as per the NABH JCI policies, we need to check the room temperature where stock medications are stored. So these all things, and whenever you are taking the medication, if the medication is need to be kept in fridge, don't place it in the patient cupboard. So all these kind of things you need to take into consideration. Yeah, now we comes into our major part, that is administration. That is a registered nurse responsibility, topmost responsibility, to give the proper medication to the proper patient at the proper time. So before talking about the procedure, we should know about the rights of medication administration. So rights of medication administration, basically there are 6 rights. When we are talking nowadays, we can see even 12 rights, no? But basically, if you're following these 6 rights, it's enough and more, no? Now, before starting the rights of medication administration, I just want to tell you one more thing. The right reason for prescribing this medication. Yeah. You might be thinking, why should I know the reason for prescribing? Yeah, of course we need to know, because a physician or prescriber may write a wrong medication for a patient. For example, one prescriber prescribed a diabetic medication. Okay, for example, glycomet 500 mg for a patient. So when you are going to administer, if you are not checking the right reason, no, you can administer this to a non-diabetic patient, because the prescriber prescribed it for a non-diabetic patient. So you just think, what is the reason for this? Maybe there might be some reason, but you need to check it, because otherwise we will also follow this prescription and we will administer the same drug to the patient who is not having diabetes mellitus. So it is mandatory for us to check whether the drug is right to this patient. That is known as right reason. This is not for administration. So before that itself, we need to check that. So for that, we need to know 2 things. One is the diagnosis of our patient, assigned patient. What is the diagnosis of this patient? Then only we can check this medication is needed or not. Secondly, the action of medication, which is very, very mandatory. I'll tell you an example. One medication error. See, once doctor advised for a perinome for a patient. Patient is after some surgery or something, resting in the ward. Means all the complications of surgery, everything he faced. And after that, he is very much stable and he is transferred to the ward. The doctor prescribed Perinom and the nurse administered Pavlone, injection Pavlone to the patient. You all know Pavlone? Maybe a bit confused. Yeah, what is this Pavlone? That's what I'm telling. You should know the right reason, right action of the medication. So this nurse is us, maybe she also not aware about this action of the Pavlone. She might thinking it can be Perinom only, no? C, it's starting with P only, so it can be Perinom. So she just administered. So you please notice the action of the drug. It is pancuronium, which is atracurium, becuronium type of drug, which is a muscle relaxant. Immediately patient get collapsed. And this patient can lose his or her life also. See, so that is the thing. You need to know the actions of the medications. And one more thing we need to take into consideration, because our patients are much more empowered right now. We are also seeing it in Google. The patient have also the access. You should know that. You should think that. So you should know the right reason, right action of the medications before going to the patient side for the administration process. Yeah. Now come back to our basic 6 rights which we need to perform while administering the drug. The first one is starting with the right patient only, because we need a patient. Without a patient, we cannot administer drug. So first we need a right patient. So you need to check the patient identity by the full name and the UHID, that is unique hospital identification number. Now come to, there should be prescription, there should be a right drug. Now come to the third thing, drug should be having a right dose. After that, dose should given through a right route, and this drug should go in a right frequency. So if you are going in a sequence, whenever I'm asking the nurses about the 6 rights, they're just confused. They just started with right frequency, right drug, right route, right. Then confusing, not getting in that sequence. So always think there should be a patient. If I'm a patient, I should be there. Then only one can prescribe a drug. Second thing is right drug. Now this drug should have a dose and the route and the correct time, that is the right frequency. And at the end, after these 5 rights, the last one is right documentation. So these are the 6 rights, basic 6 rights. If you are talking about right to refuse, right assessment, there are so many. But if you are performing these core 6 rights in a proper way, none of the errors or none of the unwanted issues will happen. So that is the right thing. Now, certain general rules for the administration. So, no self-administration. None of the patients are allowed to take the medications or consume the medications by themselves inside the hospital. See, you maybe you might be aware about the medication reconciliation. Like medication reconciliation, if I'm having diabetes mellitus and hypertension for so many years, and I'm taking the drug at home, when I'm admitting into the hospital, I cannot take it by myself. I should tell it to my doctor. And if the doctor is writing it in the medication chart, then only I will be able to take it. That also not by myself. My assigned nurse will give it to me based on my prescription. Now, no verbal orders. Already I told you, if you are following the verbal orders, one day you will be landing up in a problem. After that, the person who gave you the verbal order can deny and you don't have any proof. So, until and unless there is no emergency, please don't follow verbal orders. Now, high risk and narcotic medicines need to be checked and signed by 2 RNs. High alert medication, it is having a separate policy. So high alert medications, different hospital is having different set of high alert drug. Usually high alert drugs which all are comes like concentrated electrolytes. All concentrated electrolytes comes under high alert drug. Now this all narcotics, sedatives and psychotic drugs, then insulin. All insulins are a high alert drug, and narrow therapeutic effect. The drugs which all are having narrow therapeutic effect. Then the chemo drugs. These all are comes under high alert drug. So hospitals are having different policies about the storage, keeping all this. But usually high alert drug should be under double lock and key, and there should be 2 key custodians. And throughout the administration process, two independent nurses should be there and they should check independently. And they should sign differently. 2 nurses need to be documented also. Okay, and high alert sticker color will be different. Most of the hospitals are using a red sticker, so high alert sticker should be there. And monitoring also need to be there after the administration of high alert medication. That is the common things related to the high alert medication. So the narcotic and even LASA drugs, look-alike, sound-alike drugs, that also comes under high alert medications. So please follow your high alert policy. Label all medications, especially which is not administered. Whenever you are loading the drug, immediately put a label on that. Maybe because of some reason you might not be able to administer it immediately. So please label it and keep it. Whenever you are keeping a drug, please label it and keep it. Antibiotic sensitivity need to be checked before administration of the first dose. That is the skin test which you are testing intradermally. No? That is the sensitivity test. So certain drugs need a sensitivity test before the first dose because it can cause an allergic reaction. Explain and follow the window time. Window time means most of the hospital is having a policy. If the medication, for example, standard time is 8 a.m., the nurse can administer it 1 hour prior or 1 hour later. Some hospital is having half an hour prior or half an hour later. So whatever is your policy, you can follow that. So with the following, you should tell the patient. Otherwise, patient 8 o'clock, I didn't get my medication. I didn't get my medication. The patient will press the call bell 100 times, and they will write it in the complaint book also. So please sensitize them. Please tell them that medication we can administer 1 hour prior or 1 hour later because we have like why I'm telling you why what is the purpose like I may be having 6 patient. I am not able to administer this 6 patient medication at sharp 8 a.m. No, and even if I'm having one patient, that patient is having 5 drugs at a particular time, it's not possible to administer these 5 drugs simultaneously at 8 a.m. So that is the sense behind this. So please explain this also to the patient and follow the window times. Now, administration, the procedure, check the prescription. So you need to check the prescription first. Now, what we need to do? We need to never go for administration without a drug chart. Most of the people are just reading the drug chart. They just taking it in brain and they're going and administer maybe a single drug or something. Never do it because we need to check all the things like drug, its strength, dose, and frequency, everything we need to check. So it's not possible for us, and maybe 100 distractors are also will be there at the same time. So always go with the medication chart to the patient room and follow the 6 rights. As already I told you, you need to identify the patient by name and UHID in the patient file as well as in this wristband, as well as you can ask the patient, counter check with the patient also. So IDDRT, I'm just making a short. Identify the patient, which is your right patient. Then drug, D, drug check. Drug check, how you will check? You will take the drug and you will check it, name of the drug. Now dose check, dose also you will check. Now route check, route where we will check? In the prescription, and the time in the prescription. So this is the things which you need to check before administration so that you will never landing up in an error. Proper explanation to the patient, each drug you need to explain to the patient very properly. You need to, that patient is having the right to get the explanation about the drug which they are consuming. So you should have enough knowledge before going to the procedure, before going for the procedure. Now involve the patient in medication administration. Nowadays it is patient centered, even family centered care. So involve the patient and family. So what you are checking, thinking, telling, communicate with the patient so that, for example, one day one of the doctor prescribed Pantocid to a patient with the patient was allergic to the Pantocid. So it is mentioned there in the drug chart also, and patient is wearing an allergy band also, but the doctor by mistake prescribed Pantocid and the nurse administered that also. She also didn't counter check with this allergy things. But just imagine if she involved the patient, ma'am, I'm here. See, I'm taking injection Pantocid, and this is Pantocid 40 mg. I'm just consider this an injection vial. So just explaining to the patient, patient immediately will say, no, I'm allergic to Pantocid. So that is the advantage if you are involving the patient into the medicine administration. They will be highly satisfied as well as the chance for getting errors will be very minimized. Now come to the documentation part. So document it from the bedside itself in front of the patient. Most of the time, nowadays patient have the access to the medical records also. So if the patient is checking the drug administration time or something, most of the time patient or attendants are complaining that they didn't give this drug to me this time. They are just thinking about their care, their timing. But we have multiple patients, multiple tasks around our head. So we are not much bothered. So we cannot tell. So immediately, and otherwise also nurses are almost all the time nurses are doing a double or triple work. First they'll write in some paper, then they'll miss that paper, then they'll assume the time, then they'll document it in chart at the time of over. Why you are doing so many work? So do it systematically. You are going to the patient side with a patient file. So then and there, tell the patient, yes, ma'am. So I administered the drug. My procedure is complete. Thank you so much for your cooperation. So now it is time is 8:30 or 8:32. I'm just documenting your medication also. Document it then and there. So you can write documentation you are doing. You are not assuming, or you are just not remembering the time and you are charting it or documenting it. You are just documenting it at the right time. So please do that. Document the actual time always. Yeah. So most of the nurses, they used to follow the window period. That is 8 a.m. means 7 to 9. But they'll always document with the 8 a.m. It's a wrong thing. Whoever is seeing that record, they can understand if there are 10 medicine 8 a.m. one person cannot consume, or injection, 2-3 injections they cannot give simultaneously. So please document the actual time. Actual time means the time at which you are administering the drug. So always document the actual time, and do not do fudgy documentation. Fudgy means you are just assuming the time, or before giving the medication, yes, I'm going to give it, thinking like that, they are pre-documenting. That is also fudgy documentation. So after administering from the bedside itself, please do document. Now, only standard abbreviation. While documenting also, use the standard abbreviation if you want to. And document legibly. We are not able to read it. What is the name? What is the clock number? So legible. It should be legible. Mention if any allergic reactions happening. Yeah, documentation is not the last step. We need to monitor also. So if any new drug is administered, it's mandatory to monitor for half an hour. Just otherwise, educate the patient. If any symptoms are there, please notify us. Then record if patient rejects, vomits, or any other adverse event happens. Now, I hope till now the administration process is clear for all of you. And now I'm going to discuss about medication error. Medication error is a very, very, very poor quality indicator, because I told you already it's a core job of us, and which is should be perfect in all the way. So what are the medication error? The 5 process I told you, in each process we can land up in an error. Prescription error, wrong medication prescribed to a patient, or wrong dose prescribed to a patient, or one medication prescribed to a wrong patient. So that's what I'm telling you. We should know the right reason also. Now come to the transcription or indenting. We intended a wrong medication, or a wrong route, or a wrong dose. Yeah, that's correct thing. Wrong dose. That's a transcription or indenting error. Dispensing error, already I discussed about the Metrogyl. Instead of Metrogyl, mannitol. Both are look-alike. So if they are dispatching the same, that's a dispensing error. Administration error, if we are administering anything, wrong patient, wrong drug, wrong route, wrong dose, wrong frequency, they all are administration error. And documentation error is forgery documentation, or without not doing a documentation, or documenting in a wrong time. Now, for avoiding this or happening, follow incident reporting. Yeah, once error is happened, immediately you need to stabilize the patient. After that, you need to escalate the thing to the concerned people, consulting treating team, your head nurse, or further management team. Never hide anything. See, in the last case, I told you an example, Pavlone. So immediately, what is the only option if any muscle relaxant is giving? Intubation. So if any delay is there, patient can lose their life. So don't hide it. Okay. There is nowadays no blame culture. Error can be happen to anybody, but never hide it and try to avoid the error. Then we need to do a proper root cause analysis and post error trainings, educations, all these kind of things. So that's all about the medication error. Now come to the ADR, adverse drug reaction. What do you mean by an adverse drug reaction? Adverse drug reaction is not an error or crime or anything. It is a kind of allergic reaction. What's our key role in this? We need to monitor. We need to identify it at the first stage. So any harm associated with the use of drug at its normal dose, that is an adverse reaction. Any harm, that is any allergy or anything associated with the normal drug with a normal dose. Now you can see the levels of ADR. ADR is having 6 levels. So above the red line, it is an adverse event. And below the red line, it is the sentinel event. So level 1 means we give one particular medication and some problem happened, but no need to change in the treatment. That is the level 1. Level 2, we need to change the treatment. If I give some medication, that medication I need to change, but that depends on the further. I mean, may or may not required. It's not mandatory that I need to change in the treatment. First one, no change at all required. Second one, may or may not be. Third one, yes, we need to stop the medication which we are giving. Anyhow, we need to stop it, but no need of, but patient need an additional treatment for like antidote. Allergy happened, I need to give some steroids or something extra. That is level 3. Level 4, patient needs an intensive care, that we are shifting the patient to ICU. Level 5, patient is having a temporary or permanent loss of function in the body part. That is any morbidity, like any kidney failure or some hearing loss, something like that. Level 6 is permanent damage, that is the death, mortality. So these are the first 3 are adverse reaction and second 3 are sentinel event. Both we need to report in the ADR form. There is an adverse drug reaction form. Most of the hospital is following 24 hours. Yes, we need to report it to the further also, not only inside the hospital, further outside, I mean to the authorities also we need to notify this. So within 24 hours, we need to report the ADR to the concerned people. Now I told you already high alert policy, LASA policy, and narcotic policy. High alert drug, already I told you, mentioned you, which all are the high alert medications. You can go back to the previous minutes or previous hours and you can check it. Now high alert medication, separate marking, labeling should be there, sticker should be there, double checking and double signing, and it should be under lock and key. Based on your policy, double lock or single lock, that is up to your hospital policy. LASA, look alike, sound alike. Most of the hospitals are following Tolman lettering. Tolman lettering in the sense, for example, two drugs, which is sound alike. So atracurium or atropine. So ATR is common in both. So they will write ATR in small letter, remaining OPINE in capital letter, where we need to concentrate more. So that is Tolman lettering. So most of the hospitals are following that. Then separate marking should be there, and double checking and double sign under lock. Narcotic also double lock and key custodian should be there, and keep only in designated area. We cannot keep narcotics in all the areas of the hospital. Narcotic form should be filled, and wastage policy need to be followed. Wastage policy means if you loaded Fenda 100 mg and you need to give 50 mg only to the patient, that is in 10 ml you diluted all and you need to give only 5 ml, remaining 5 ml will be waste. So how to do it? I mean, how to proceed? Whenever you are wasting a narcotic, you should waste it in front of a doctor, senior person. And policy either into the running water or into the yellow bag. That is up to your policy. So whatever running water policy you are following, you can do it in front of a witness, or discarding the medicine into the red bag, that also you can follow, but in front of the witness. So I hope there is no queries, and already you might means attended the pre-test. So now there is a post-test also. So hope all the things are very, very clear for you, and you will score 100% in the post-test. So wish you all the best, and kindly start a proper medication administration procedure, and all the best.